All right, guys, how are you? Okay, so before we start, let me tell you how you're gonna be using this video today. Because I think if you try to use it the wrong way, you're actually gonna get burned out. This is actually gonna be a long med search video, so it's not meant for hardcore memorization, just to watch it once and oh my God, I memorized it. No, no, no. This is more of a concept building video, okay? So here's the deal. I want you to grab some coffee, tea, water, whatever you like. Just get comfortable. You don't need to pause every 10 seconds. You don't need to be writing everything down, okay? So I just want you to chill and try to understand the logic of everything behind this, okay? Of what's happening on the GI system. So you will be able to see that most of these conditions, most of this stuff is actually just the same few problems. They're just presented in different ways. So don't stress, don't rush. If something doesn't just click the first time, that's okay. All right? So let's start. Okay, so some people divide the GI system. This is the whole GI, of course. Here you have the mouth. Here you have a beautiful mouth. Here you have your esophagus, your stomach, the small and the large intestine. All right? This is what we call the main organs of the GI, or the gastrointestinal tract, because it's like a track, like a race track. It's just one full line that ends up in the anus. Oh, yeah, okay, so, all right. Now, we also have something that we call accessory organs. The way that was able to memorize this is just think if it's not a tubing, everything else is next to a GI is mostly an accessory organ. That include teeth, tongues, you can even almost say the lips. You can say the liver, the pancreas, all the salivary glands that are located around the mouth to help you with the saliva, all right? So everything else is that it's not a tubing and it is part of the GI system. That's what we're going to be calling an accessory organ. Now we're going to do a little bit more of a detailed overview. So again, GI system starts in the mouth, all right? And as I mentioned, this is the part when we start with digestion of the food and initial processing. Food is here is just breaking down mechanically because the teeth, the tongue moving around. And here we won't be having too much absorption, but there's some the absorption of nutrients in the mouth, especially of sugar. Just put some sugar over your tongue and you're gonna notice that's gonna get dissolved with the saliva. And even if you don't swallow that saliva part of it, the sugar is gonna go inside of your blood system. Now, next we have the esophagus. All right, as I mentioned, this is just a tubing to get to the stomach. This esophagus is mainly a muscular system, like pure muscles all around. Why? Because we need something called peristalsis. Peristalsis is when all those muscles are moving and wiggling around to move the food that is inside them. All right, that's called peristalsis. And it's going to be happening all the way in the whole GI system. All of this muscle, all this structure has muscles inside, and they contract in synchrony by doing that they're going to be moving all the bolus inside. All right, important. In the esophagus there's no digestion, so it would make sense since food is actually falling. There's no time to be doing any digestion or absorption here, right? All right. Okay, next we have the stomach. As I mentioned again, it's gonna be a holding, it's like a warehouse, it's like a chamber to the chamber of secrets. It's just to keep the stuff here and hold it with a little bit of acid to help digest the food. Why do we need acid? Well, proteins are a little bit hard to digest, so we need to break them down into more simple components. That's why mainly we need acid because it has protein digestion. Also, um, there is a lot. Most food and mostly everything has a lot of bacteria, good and bad bacteria. So the stomach, this acid is going to be killing a lot of the bacteria to protect us. Other functions of the stomach will be some absorptions of certain nutrients, especially vitamin B12, calcium, and iron. B12, we're going to be talking later about it. So just think acid kills the bacteria, helps digest proteins or nutrients. And the stomach also helps absorption of something called B12, vitamin B12. All right. Now, close to the stomach, we have the liver, which is an adjacent structure for the GI. The liver produces something we call bile. What is that? It's pretty much just a substance that's going to help us digest the fats. In the same way that the stomach acid helps with the digestion and the breaking down of the proteins, we need something to help us break down the fats and help us digest the fats and be able to get the fat inside our system. That's when bile comes in. We need bile to help with digestion of the fats, all right? So the liver produces the bile, and that bile is stored in a place here called the gallbladder. It's a little sac, and the little sac stores that and send it through a tubing all the way here. Oh, it's here, the tubing, all the way here into the small intestine. Oh yeah, all right. Okay. Also, as I mentioned, there is a tubing here. In the pancreas, which is another organ that produces enzymes. Enzyme is a type of it's a structure, it's a type of protein that helps break down other structures. So it's pretty much like a machine. Is like a chainsaw. It's gonna be coming here to help break down almost a lot of carbohydrates, proteins, and fats. Same way, it's gonna be helping destroy all those because all the time the food is like this size, right? You eat it and it gets smaller. But then we need even to get it even smaller so we can actually digest it. And the enzymes destroy stuff and get it like really, really, really small. Next we have, I mentioned again, I just want to, okay, this is, I think, the only thing that I want you to remember mainly about the function of the small and large intestines. The small intestine, if I'm telling you, if this is part already of the small intestine starting here, blah, 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 in the duodenum, the jejunum, and ileum, and I'm telling you, oh, digestion with the enzymes and the bile here, just think small intestine is digestion and absorption of nutrients. That's it. Nothing else, nothing more. Now, the large intestine it looks a little bit bigger, right? What do you think is large? Well, we had to pretty much we're just absorbing water and electrolytes. So we need space because the bolus is gonna start getting bigger. Because in most of the small intestine, the food is pretty much more like liquid, right? That's why it's small. There's no you don't need to make it. You don't need a big tubing for just moving water, but you need a bigger tubing and more muscle, like here, for to start moving like more dry stool. So large intestine is going to be absorbing the water and electrolytes. So pretty much it's going to make sure that there's no fluids or nutrients being lost, but it's just mainly water and electrolytes. That's why poop comes out dry. Nice, huh? Okay, so last part of the large intestine is the rectum, this sac here. So what is the rectum for? It's easy. It's just it's a holding chamber for feces. Feces is gonna be a hole here, and that's it. At some point, it's gonna be enough. So you're gonna start feeling the urgency to use the restroom, and these two sphincters there, one an internal sphincter and an external sphincter. The external is the one that you control, this one, and this one you actually don't control it that much. Is controlled by your parasympathetic system, and this is going to activate once the rectum is already prepared with a lot of pieces to go out. All right, so let's start talking about the actual conditions. And I want to start with gastritis. What is gastritis? Okay, this is how I think about this. The stomach has acid, right? Too much acid leads to inflammation. Too much inflammation and acid can damage the actual stomach walls. They start getting destroyed, and that's what we call an ulcer. It's a destruction of the walls, okay, because of the acid. And the wall, as it gets destroyed, it can lead to bleeding because remember we have the stomach is covered for a lot of vessels, arteries, veins, all the GI system is. So if we have a wall and behind is, let's say these ones are the all the vessels, is the blood behind the wall. As the acid of the stomach start moving and destroying the wall, at some point it's gonna touch those vessels and we're gonna have bleeding, right? All the bleeding in the stomach. So this is the simple way of seeing gastritis. Okay, now again, gastritis, you have a lot of acid, leads to inflammation. Too much acid can lead to an ulcer, and too much of that can lead to bleeding or a perforation of the stomach. All right, so in general, what stuff can lead to this gastritis? What causes can lead to this? Okay, the first thing, the first and most important one is something called Helicobacter pylori. This is a bacteria. It's a nice, beautiful bacteria, and this bacteria is gonna lead to inflammation, infection, right? As any other bacteria. In this case, since it's in the stomach, it's gonna be gastritis. That's simple. Helicobacter pylori, gastritis. All right. There are other bacteria, there are other viruses, other parasites that can lead to gastritis. But to be honest with you, most of the time, the cause is gonna be Helicobacter pylori. Now, all the stuff can lead to gastritis. Well, we also the use of certain drugs, especially non-steroid anti-inflammatory drugs like ibuprofen, naproxen, aspirin, are gonna lead to gastritis because these drugs are gonna be affecting the action of prostaglandins in the stomach. Without prostaglandins, the stomach won't be producing the protection barrier against the acid. So these drugs here are gonna be limiting how the stomach can respond to the acid. They're gonna make it weaker. So yeah, that's why these drugs, non-steroidal anti-inflammatory drugs, blocks prostaglandins, and by doing so, you're gonna have more acid effect. What are the stuff? Well, in general, I like to think on this like this. I only memorize these two, and all the rest of the causes are in general anything that damages the stomach lining or anything that damages your health in general. Like what? Oh, alcohol or smoking. At this point, tell me something in nursing school or medical school that alcohol is good for or smoking is good for. No, 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 nothing. You know, alcohol and smoking is always bad. Stress destroys your whole body. So too much stress, you ended up with gastritis. Oh, autoimmune disease. What is this? Okay, simple. Um, it's basically your body defense, your white blood cells, your defense mechanisms are gonna start attacking certain cells in your stomach because they're gonna think that those cells are enemies. It's pretty much he forgets or as they unable to recognize that some cells of your stomach is actually your own stomach. It's gonna start attacking those, and by doing so, you're gonna have gastritis because it's gonna be attacking and gonna be destroying the stomach lining. No stomach lining, more acid acting, more acid, gastritis. Simple, right? So just memorize these two: medication and Helicobacter pylori, and everything else is gonna come to you just by logic. Now, there's two forms of gastritis. We have acute one and we have chronic. Oh, well, how do we know which one is which? Simple. If you get a patient who arrives to the hospital with a lot of pain that started sudden in a short term, like out of nowhere, that's acute. Now, if you have a patient that say, "Oh, I've been having gastritis for some time, but now I feel worse," blah blah. Oh, that's chronic gastritis. He's been having gastritis for some time, but maybe arrived to the hospital because the gastritis is getting an acute phase, or because of the gastritis they're having other problems like ulcers, B12 deficiencies. It's a cancer. All right. So acute gastritis is just something that happens sudden in short term, What can cause this? Well, irritants, alcohol, too much of certain drugs, as I told you before, too much stress, like the finals, so like another severe illness. And usually, since it's a sudden short-term pain, a lot of times we getting the risk of the patient having hemorrhage or necrosis in the area. All right, which is necrosis means the tissue will die. All right, but don't worry. In general, acute gastritis is often reversible. Most of the time, you just it's the patient that started with gastritis and you just start treating it based on the cause. Now, chronic gastritis, patient has been suffering from gastritis for some time, couple of months, a couple of years. Um, Main cause for this, as I remember always, H. pylori is the most common cause for chronic gastritis, the most common one. Complications, ulcers, B12 deficiencies, anemia, and gastric cancer. Why B12 deficiency? Remember I told you that the stomach help absorb B12. If the stomach cannot absorb B12, deficiency of B12 because of the damage of the stomach. If the stomach is getting destroyed all the time and damaged because of bacteria, there's a risk for cancer. If you are bleeding and also without B12, you're not producing red blood cells, so you can have anemia. And ulcers, I mean, you don't have to think on this one. I already mentioned that one. All right. So, okay. So this is chronic is more like progressive. Think on the total. It gets slowly, slowly, slow. It's often progressive and it can progress a lot if you don't treat it or they don't treat it on time. Okay, so how do we know what is the cause of the gastritis in the patient? Because the patient is going to arrive saying, oh, I have stomach pain. And I feel maybe like reflux or I just have stomach pain in general. How do you know? Well, we have tests for that. In general, a good stuff is just looking directly into the stomach, right? It's just that you had an issue, just look at it. So we're gonna use OPGA studies like X-rays. We can have endoscopy, like this dude here, right? They put this camera inside your mouth through your mouth, and they can actually see the stomach. Wow! And they're gonna be able to see what is there like. Make sense? We can also do a biopsy, which means we're gonna take a small tissue sample of the stomach and we want to check on the lab to see if we find something there, maybe cancer, H. pylori. Now, there are other tests for checking if there's bleeding happening in your stomach because of the gastritis, or if there's bleeding happening. In general, these tests are gonna be called, we're gonna be checking for bleeding that is hidden. They usually call it occult blood. Because if it's not that much of a bleeding, it might be imperceptible visually when you look at the feces. So we check for hidden occult blood. There are three names that comes to mind when you hear about those. They could say WIAC, hematest, hemoccult. It's just the same stuff. It's just three tests. It's the same thing. I mean, I'm not saying the same thing. You know what I mean? But it's just three tests to detect hidden occult blood. If they happen to find hidden acute blood, what does that tell you? Oh, there might be an ulcer that is progressing. Make sense? All right. So, yeah, here another diagnostic test. We're gonna be checking for H. pylori. I mentioned this one. This is the big one. This is the bad dude producing the gastritis. Let me put it like this: the teeth. It's a bad dude producing the gastritis. We have to check if the patient has that. Because if it does, that now how do we know how to treat the issue? How though? So for this, we can do blood tests because there's gonna be antigens, there's gonna be elements of the thingy in the blood, and we can detect if this thing is on the blood, is on their body. We can do stool antigen tests, which is checking for the presence of this, but on the feces. And we can do something, the most important one is urea breath test. Breath test. So, what is that? So, it's pretty much something like this. It involves a special, they give you like a solution with something called urea, all right? That goes into your stomach. Now, this bad dude here, the Helicobacter pylori, pretty much is gonna once he finds he produces something called an enzyme to be able to survive in the stomach acid, and that enzyme destroys urea and turn it into CO2 that can be detected in the blood. So when you do the urea breath test, you give urea to the patient and then you check the blood. If you notice that the CO2 levels go too high after the urea test, that means that the urea was turned into CO2. Who's turning urea into CO2? Yes, Mr. Helicobacter pylori. All right, so urea breath test, we give urea. If the Helicobacter is there, it's going to turn it into CO2, which is going to raise in the blood system, and you can detect that CO2 in the patient. Now that we know the actual cause, what is it? How do you treat gastritis? Well, if your stomach hurts and it's inflammation, is in any in most parts of your body when there's something wrong, you leave it sometimes to rest a little bit, right? So we're gonna put the stomach into gastric rest. That means we might give fluids to the patient and electrolytes while keeping him while not eating anything. Once he's able to eat, we can give him some bland foods, especially, and you're gonna hear these terms a lot in most of the GI conditions, small frequent meals. You're gonna see this in almost all GI conditions. Most of the time you want small meals and more frequent. Why more frequent? Because the patient actually needs to feed himself. You don't want him to have weight loss. So that's why, since they're small meals, they need to be more frequent. All right. What else do we do? Well, if we know that the patient ended up with gastritis because he was drinking too much coffee, spicy food, alcohol, or because of the drugs that we mentioned, we're going to then, as simple as it is, eliminate those irritants. You're gonna be like, Jimmy, you cannot keep getting those. We're gonna talk to him. We're gonna try to convince him to find a way of substitute this for another stuff. In that way, there's gonna be less irritants in their stomach, and less gastritis. Now, what if the gastritis is because of Helicobacter pylori? What do we do there? Simple. This is a bacteria, right? Just give it antibiotics. That's simple. Okay. So for this is you're gonna see this a lot in nursing school or in medical school. We use something called triple therapy. What is that? We use two antibiotics, one proton pump inhibitor for the acid, and this therapy is usually gonna last around 7 to 14 days. We call this triple therapy. Is whenever you hear this, that's usually treatment for Helicobacter pylori and includes one proton pump inhibitor and two antibiotics. So just think bacteria. Oh, I use antibiotics. Stomach, you're gonna be using pump inhibitor, proton pump inhibitor for the acid. That's simple. Okay, there are other medications that we use. So just think on this. If you finish pharm already, you're gonna know what kind of medication do you use for acid in your stomach. Gastritis, acid. What are those? Proton pump inhibitors, PPIs. Those are the ones that end in prazole, like omeprazole, pantoprazole. These are the first line therapy, all right? Because they prevent your body from producing the acid. So if there's no acid, there's less pain in your stomach, less inflammation. We can also use H2 receptors antagonists, which are all going to reduce the acid secretion in your stomach. This doesn't block the production of acid, they just make it lower, but they reduce it. So they are less potent than PPIs. We can also use antacids, which is what? Well, we have the acid in the stomach already. You put an antacid, let's say that the acidity level is 4, and with the antacid after that, the acidity level ends up in 6. which means it's less acid, the pH, sorry, the pH. You know the pH, the higher the number, more alkaline, the lower the number, more acidic. So antacids are just drugs that we put inside the stomach acid to increase the pH value, so the stomach acid is more alkaline and less acidic. So we are neutralizing the stomach acid. And something else that sometimes they use is sucralfate, which is not something to alter the gastric pH. We're not changing the pH, we're just putting a coating, a protective barrier over this damaged gastritic or mucosa. All right? All right, so let's go a little bit deeper about peptic ulcers. All right, so I already mentioned it. Acid, inflammation, inflammation leads to ulcer. Too much ulcer, we got bleeding or perforation. All right, so peptic ulcers are pretty much just open sores, erosions on the lining on the GI. We can find them. We have three main places. It could be esophageal, gastric, or duodenal. You know, based on the location. The name already tells you where is it. Now, the main or more important for all of those is the duodenal ulcer. It's the most common one, at least 80% of all cases, which is a lot. So esophageal, gastric, and duodenal ulcers. All of them are open sores or erosions. So what are some of the causes for these ulcers? Well, as I said before, most of this stuff is just acid. It's related to gastritis. So same as in gastritis, it could be because of an infection of a gram negative. Can you guess which one? Yes, H. pylori. So same as in gastritis, almost same causes. Um, the treatment and diagnosis are really similar. The thing that you have to remember when it comes to ulcers is that patients with peptic ulcers often have gastritis. So these two things go hand to hand. So then what about the symptoms? Well, we're gonna be having burning stomach pain. I mean, this is an ulcer, right? It's an opening here. It's a sore. So we're gonna have stomach pain. If you have stomach pain and it hurts, you're gonna be having some nausea or vomiting also with the gastritis, right? Now the sore damages the stomach lining, and that can cause also gas to build up. We call that bleaching. And since we're talking about gastritis and ulcers, we're gonna be having some irritation. Now, severe ulcers can cause swelling, and that can slow down the emptying of the stomach. That's why patients with ulcers can have um, feeling of fullness. And remember, I put this image, this drawing here, but ulcers to be located here or here. And inflammation in those areas are gonna make the GI movement slower peristalsis. So we're gonna have more emptying or fullness. Okay, so the main two type of ulcers are gonna be gastric ulcer and duodenal ulcer. As I said before, this is the most common one. Now, how do we know how to differentiate between these two main types? Okay, for the gastric ulcer, since it's right in the stomach, food goes down, and in just a little bit of time, 30 to 1 hour after meals, you're gonna start having the pain. Because it's right here, right? It's shorter. It's right here. Now, if it's 2 to 3 hours after meals, you already passed the stomach, so it's gonna be duodenal ulcer. So if it's short time, close to the stomach, is 30 minutes, 1 hour, gastric. If it's a longer time, duodenal. All right. Now, with gastric ulcers, since the stomach produces acid to digest food, you're gonna have more pain with food. As you eat, you're gonna have more pain. The pain is gonna worsen with the food. But if it's duodenal, pain is gonna be relieved by the food. Because the more food is gonna be help a little bit to neutralize the amount of acid in the duodenal part. That's why a patient with duodenal ulcer is often gonna feel like eating a little bit more. It's gonna relieve the pain. Now, because of these two relationship with pain, we're gonna have weight loss and weight gain. And it will make sense because if you're having pain when you eat, do you think do you want to eat more? No, right? And you're gonna be like, oh, I cannot eat this, I cannot eat that. So you immediately is gonna start having some weight loss. But by the contrary, if you're having pain that gets alleviated by eating, you're gonna be eating more. So that will lead to weight gain because you want to relieve the pain. Make sense? Now, gastric ulcers, because it's the stomach and it's closer to the mouth, we're gonna have a lot of more risk for vomiting. All right. Now, the duodenal ulcer, since it's closer to the anus, is more and more common to have dark tarry stool or melena. What is dark tarry stools? Just think that in the stomach acid is mixing with the blood. And as the stomach acid mixes with the blood, it's just like simple color matching. If you just think that blood is, goes from red and the blood gets coagulated and the stomach digested, you're gonna have brown poop, melena, tarry stool. All right. Now let me go back to my favorite color. Here we go. Okay, so in general, gastric ulcers are usually more for patients that are older, like 50 to 60 years old, and duodenal ulcers are mainly more for in this range of age. Okay, so the way I think about it or remember is that I think that usually ulcers we have it when we're working really hard because of stress, you know, and this is the usually a time of your life when you're working a lot, so that's why you're having duodenal ulcers at this time. And gastric ulcers, usually when you get older, your stomach start getting more thinner. So it's not so much about stress, but also about you getting older and the kind of food that you're eating and too many stuff together. So gastric ulcers 50 to 60 years old. Now gastric ulcers are usually going to be presenting here in the lesser curvature of the stomach. Duodenal ulcers, of course, is going to be in the duodenum. All right. Now let's talk about something that is related to gastritis and ulcers. This is called Zollinger-Ellison syndrome. What is this? Well, some patient has a type of cancer, a type of tumor called gastrinoma. All right? This type of tumor is special because it produces a lot of gastrins. Gastrin looks like, what do you think? Yes, it sounds like stomach acid, like gastritis. So they're gonna increase the amount of level of acidity and acid in your stomach. So you're gonna have more gastritis and peptic ulcer. So Zollinger-Ellison syndrome is a gastrinoma, is a tumor in which there's a lot of acid production, and that leads to gastritis and peptic ulcers. So the symptoms will be burning, stomach pain, nausea, or vomiting, right? Same as before. The salt damages stomach lining, causing gas buildup. Same symptoms is the same stuff. All right. Now let's talk about GERD, gastroesophageal reflux disease. So reflux, you already know that, right? Acid and the stomach acid is going up, and you feel a pain in all these area. Why is the stomach acid going up? Doesn't make sense, right? Of course it doesn't, because usually we have a door, we have esophageal sphincter, which is a musculature around the esophagus in this part that is closed, preventing the food from going up. So with acid and because of other causes, this sphincter can start getting like weaker, right? This door start failing and the acid is gonna go all the way up. So it's gonna feel more like chest pain rather than stomach pain. Why chest pain? Because the lungs are here and the patient's gonna be like, oh, it hurts in my chest. I mean, it's not the chest where it hurts. It's the esophagus. It's just that the esophagus is, right behind. Okay, so What are some causes of this door failing? Pressure on the stomach. If you start, imagine this is a balloon, if you start putting some pressure on it, the content has to go somewhere, up and down, you know? So if you are obese, overweight, you're pregnant, or wearing really tight clothes, you're putting more pressure on the stomach. So the food has less space, so it's going more food up with acid and more food down. All right. Other stuff are hiatal hernias. I'm gonna show you an image after. We're gonna talk about this after. Don't worry too much about it. But basically, it's a hernia is the part of the stomach. Here in this part, we have the diaphragm. It's like a lining dividing the. Oh, sorry. Here we have the diaphragm. It's like a lining dividing the. Let me put it like this. It's a muscle, right? Separating lungs, thorax from abdomen. Okay, so part of the stomach sometimes can move above that, and that's called a hernia. Part of the structure of the stomach moves to the other side, and that's what we call a hernia. We're gonna talk about that later. Don't worry. Now, what other stuff can lead to this? Well, relaxing triggers can lead to reflux. Relaxing triggers will be stuff like nicotine, alcohol, caffeine, fatty foods. It's just think anything that is not healthy. You're gonna be weakening your body in general, all right? And it's gonna be leading to this sphincter working less than expected. Okay, so what are the symptoms then? As I said before, you're gonna have some heartburn that we call this pyrosis. It's gonna be a chest burn, it's gonna be like chest pain, but it's coming from the esophagus. We can have water brush. What is this? It's a lot of saliva. Why? Well, at this point is you have so much acid that your body's trying to neutralize it somehow. So you're gonna start producing a lot of saliva. They're gonna go down the esophagus to try to neutralize a little bit the stomach acid. Because the reflux is going up, you're gonna have regurgitation, dysphagia, problem with swallowing, indigestion. Now, part of the stomach content can go up, and you know what's up also? Yes, if you thought about lungs, you're right. Part of the stomach content can go through the trachea and can come to the lungs. So all this can cause some respiratory issues because part of the acid can end up in the lungs. Here we call this aspiration when the stomach content is going to the trachea and going to the lungs. And the aspiration is in general going to be leading to something called pneumonia. We see this a lot in all patients. We're going to have some hoarseness, which is our voice is going to sound a little bit more rough or low, and that's because of the acid. It's going to hurt to talk. You have bronchitis, your lungs are getting damaged because of the acid. Esophagitis, inflammation in all the esophagus. And yes, the acid goes so high, keep going high, and the gas that is going out of your stomach is going high, and all that gas, all that acid, is that ends up in your mouth. So you're gonna have some tooth decay. All right. So remember, GERD it's not just the stomach, it's not just this part here. It's all the way up. Acid keeps moving up to the mouth and to the lungs, and also the gas. It's not just like liquid acid; it's also the gas accompanying the acid. Okay. So how do we treat GERD? I mean, it's the same stuff, right? If you have acid, how do you treat acid? You give PPIs, H2 blockers, antacids, right? That's it. Okay, how do we help also strengthen here this connection, this sphincter? We can avoid alcohol, prevent this from smoking, fatty foods, better diet, right? This is really most common for this one. Elevate the head of the bed after meal, and small meals. So once the patient finish eating, instead of laying down, we want them to be like standing or kind of like sitting, because in that way, the stomach acid is not going up because of gravity is keeping it down, right? So we want to keep the patient elevated, the head of the bed after meal, especially if ideally a little bit seated. Okay, so we also had to protect the esophagus, and we had to think on in extreme circumstances, we might need surgery to treat this. So if the whole idea here is just we have acid, rather just PPIs, just neutralize the acid. If by any chances we have Helicobacter pylori involved, treat the Helicobacter pylori. Avoid anything bad and try to have a healthier lifestyle. Elevate head of the bed after meals and small, more frequent meals. Okay. For the diagnosis, there are some diagnosis tests related to only GERD. And personally, you know how to. I think you know how to memorize them. As soon as you hear something saying esophageal, esophago, or esophageal, I mean that's GERD, right? That's it. Gastroesophageal, esophageal. You don't have to memorize these terms. Whenever you hear any test mentioning esophagus, most probably you can use that to determine if the patient has GERD.